and so I am pleased to be moderating this session. Across our efforts to control the global HIV epidemics, we have measured our progress against our targets, from 3x5 to 90-90-90 to treat all. We have also learned that we constantly need to assess and reassess how reliable our data are, and most importantly, to prioritize the people, the places, and the communities behind the numbers. Today's special session will emphasize the critical importance of how we collect and interpret HIV epidemic data in order to design interventions and programs and monitor their effectiveness. It is now my pleasure to introduce Ambassador Deborah Birx, who will be our first speaker for this session. Ambassador-at-Large Deborah Birx is the coordinator of the U.S. government activities to combat HIV/AIDS and U.S. Special Representative for Global Health Diplomacy. Her 3-decade-long career has focused on HIV/AIDS immunology, vaccine research, and global health. As the U.S. Global AIDS Coordinator, Ambassador Birx oversees the implementation of the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR, and all U.S. government engagement, the Global Fund to Fight AIDS, Tuberculosis, and Malaria. Serving as U.S. Special Representative for Global Health Diplomacy, she aligns U.S. government diplomacy with foreign assistance programs that address global health challenges. Ambassador Birx began her career with the U.S. Department of Defense as a military-trained clinician in immunology, focusing on HIV/AIDS vaccine research. Please join me in welcoming Ambassador Birx.
Thank you. That's the only co-chair I've ever let finish the introduction. Thank you. That was lovely. And thank you all for being here. I want to talk a little bit about data and how we're utilizing it, but I wanted to also spend just a moment, hopefully, okay, great. Talk about our data related to young women, because this is one of our newest programs, and I wanted to just speak to that in a little bit detail. But I wanted to also give us kind of a self-assessment. I was really intrigued by the opening and really hearing a lot of our gaps and our needs. And so I thought I would go through and kind of give you my view on where we are. I also note after the opening that there are many countries with very strong health systems and very strong primary care that have less than 15% treatment coverage and no access or very little access prevention services for those who need them. So although we are all working towards primary care access and universal health coverage, we have to address the structural barriers that are keeping us in these countries that already have very high rated by WHO health systems. So this is how I grade ourselves as a global community. I think our impact on the key population epidemics is an F. And I think that if you look at across the board of what UNAIDS has presented, every key population of what we used to call concentrated epidemics have really failed to really reach any significant coverage for both prevention or treatment services. When we look at comprehensive programming for both men and boys, because I'm going to be talking about girls and women, and whether we're addressing the unique needs of men and boys, I kind of give us a C. I think we've done extraordinarily well in voluntary medical male circumcision as a primary prevention intervention for men. I think we will reach the 25 million circumcisions by the end of 2020. I certainly know from PEPFAR's standpoint we'll get very close to that on our own. Whether we have comprehensive early treatment and viral load suppression for men and boys, this is really a C-. The only thing that's pulling us up is the men versus the boys. Men under 30 are not virally suppressed. Retaining young people on treatment, this has particularly become evident as we all have moved to treat all, and we are not retaining people under 30 on treatment. And then universal access to condoms. I didn't say universal supply, I said access, and I think that's more of a C. So here's the good story of voluntary medical male circumcision. We're at an all-time high again this year. Last year was an all-time high for us. About 3.5 million circumcisions were done last year. We will probably surpass that. This is only the first 2 quarters of 19, and we're all at well over 20 million cumulative circumcisions, and all countries are performing well. But this is what I was talking about viral load suppression. Children We're missing the majority of children, and children are not virally suppressed. This is from our FIAs. These are comprehensive community-based surveys done across the board. I want to just thank CDC and ICAP for their strong work, and now University of Maryland for their work in Nigeria. But look at both the males and females highlighted in pink. We can see that the majority of these individuals are not virally suppressed, and I think that's why I give us a low grade for that. Even in Namibia, who's at 94, 96, 95, we're missing 35% of men between age 30 and 34, 40% of men between 25 and 29, and these are just HIV positive, unaware of their status, and 40% of young men between 20 and 24. These populations look small, but they're critical if we're going to actually control transmission. We're also preventing them from getting treatment before opportunistic infections. The majority of our men are still presenting late. So that was kind of our advertisement of where we are in the program, and I think it's important for us to recognize those gaps because we do have a unique opportunity. We want a strong, replenished global fund, but we also have the opportunity with a new set of concept notes coming to really demand that key populations and missing populations be included in every concept note. Even in generalized epidemics, we know key populations are underserved. And so we could ask for that as a community. And now that we have the new executive director for UNAIDS being recruited, we also need to ask for, as Tantan talked about, someone who is really aware of the epidemic and grounded in science. So leading into my talk about young women and access to services, about 4 years ago now, we had launched DREAMS, Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women, a comprehensive structural intervention looking at the lives of young women, asking them what they need, putting them at the center, and designing a program. Why did we do that? Because since 2009, we've been providing primary prevention to boys and men through voluntary medical male circumcision. And so we had that component, and we had condoms, and now we have added PrEP both for young girls, key populations, and young men. But we were missing particularly this one element, 25 to 35-year-old well men who were not diagnosed and not interacting with the health center. So DREAMS and data, and how we're using DREAMS to really understand how to do programmatic improvement as we embarked on this really unique program of comprehensive structural interventions for young women. 15 DREAMS countries, we started with 10. We believed, and when we saw the early data, that we were making progress in unique ways. We expanded the program to include additional countries. And then countries that had done really well in the districts, we started in the highest burden districts. In the countries that were doing well, we allowed them to expand to additional districts. Data as a key resource in every phase of DREAMS. So data was critical for that very first circle, establishing the needs. And I purposely put the young women behind this slide because at each single data point, it was the young women who actually told us what they needed for structural interventions, and that's the number 2 circle of really listening and understanding what the needs were. Identifying the issues that they face, identifying the interventions that address that issue, not the issues that we thought they had, but the issues that they said they had, and then designing the interventions to address those issues. Why is that important? Up on the far side, I show you the prevalence in women. Those are the light green bars. You can see how they're dramatically different at every age group, up and, well, in this case, through all age groups. This is Zambia. Women have 2 to 3 times the prevalence of men at every single age band. And so after identifying the issues and the interventions, we worked, and we were very excited because Pop Council brought us this girl roster, which really looked into the community and really got to the individuals in the community to really assess vulnerability and risk. And then monitoring our implementation, evaluating impact for program improvement. And this really gets to my core point. There's no point in collecting data unless you use it to design your program and you use it to constantly evaluate and programmatically improve. So the DREAMS partnership, which was announced in December 2014, it took us almost all of 2015 to plan this program and have it rolled out. It started as a $300 million public-private partnership with the Bill and Melinda Gates Foundation, Gilead Science, Girl Effect, Johnson & Johnson, and ViiV Healthcare. We added risk and innovation challenge with very new 50% of the individuals who received money under this had never received PEPFAR money before, and they were mostly indigenous organizations. We've continued our investment. We have nearly $905 million of direct DREAMS funding for the last 5 years, including this year going forward. Just to put that into perspective, we've invested $1.5 billion in VMMC, another $1 billion in OVCs over that same 5 years, and then $3 billion in ensuring access to testing and treatment for young people. So this is the DREAMS package, again, very much focused on putting the young woman at the center and reducing their risk based on improving their issues and their structural issues, either through the families, reducing their sex partners, and most importantly, mobilizing communities for change. All focused on using the best evidence that was in the literature, understanding that girls who stay in school through age 19 have a lower HIV incidence and prevalence, preventing early pregnancies, critically preventing sexual violence, but if it occurs, providing post-violent care and reducing child marriage. So, what are our findings? We first reported findings that the majority, 60% of the DREAMS districts showed a decline in new HIV infections among adolescent girls and young women attending our ANC clinics. In 2018, just a year later, we show that new diagnoses continued to decline in 85% of those communities, and in 8 DREAMS-supported districts had not seen declines before, had declines in that year. These are the districts. Although our services may be in specific areas in the district, we count the entire district to ensure that we're having an impact across that district and the community. Again, this was the original 10 countries, and these are the districts that had less than a 25% decline, and you're probably wondering what countries does this correlate with. So in Kenya, Lesotho, and Malawi, 100% of the districts had more than a 25% decline, and I showed you that decline right there. It's between 30 and 35%. 50% of the districts had a greater than 25% decline, and you can see those countries and declines that were across the board. And then we had 2 countries where less than 50% of the districts had a greater than 25% decline, and these are often highly urban areas. And this started to give us some insight into whether the program was working equally well in urban and in rural areas. I wanted to give you our most recent PrEP data, which continues to expand. I showed you the light yellow bars are our fiscal year 19 targets. That's where we are right now. And you can see year over year we've had continuous expansion of PrEP. I will say getting PrEP available to young women had a lot of barriers. In many countries, they restricted us to female sex workers, young female sex workers, for our first access to PrEP. We've been able to actually move that policy, and you can see our 2019 goals for PrEP, and again, based on the vulnerability of the girls and their risk, assessing PrEP. In South Africa, we were very encouraged with the recent data to really begin to see declines in incidence and rates of new infections in young girls in these highly urban areas of Johannesburg and Durban. And we're excited about the momentum that could be building there. But the important thing is we continue to use data to both improve the efficiencies of the packaging. We found that in talking to many of the countries, when we have many data sources, and I want to thank Gates for having an independent evaluation of DREAMS, because they constantly gave us feedback of what they were seeing in the field and how things needed to be improved. So we found gaps in accessing, and you'll hear this across all of our treatment and prevention services, this layering. And what do we mean by layering? It's another word for integration. Is it easy for young women to access the different services? Is it given in one place? Is there a handoff? Is there ensuring that each girl? So we created a new indicator around this, because we know when we create indicators, all of our partners take that as a key element of the program, and we'll start really intentionally layering. We also made it very clear in the COP guidance that you needed, if you didn't have it all centrally located for the girls, you needed to actually have it not passive, but active transfer for access. We found that a large number of our adolescent girls and young women were dependent on transsexual sex to meet their needs. This was from Population Council data, but also our site visits and our observation, and frankly, sitting down and talking to the young women. The action that we've taken is we've been working with all of our PEPFAR teams to provide more evidence-based income-generating activities to support a living wage among our young women. We also have been following up with economic experts in the private sector and country teams to really explore this critical bridge, what we think is between 19 and 24, where young women are particularly vulnerable with this need for meeting their needs through transactional sex, and to really including access to universities and figure out how we provide more economic opportunities. We also continue to evolve our Orphans and Vulnerable Children's program, which was very much focused in the early years of PEPFAR of under 5 children. And our partners in our Orphans and Vulnerable Children's program, I think you can see that light orange and dark orange. That's 10 to 14-year-olds and 15 to 17-year-olds, and intentionally evolving the program to meet the children and the adolescents in their homes and ensure that they have adequate care and access to schooling and other issues. They also have become the support group to our adolescents who need to be on treatment. Finally, ensuring justice for children. These are the violence against children surveys that we've had in the field for a number of years across many countries. This shows you the percentage of first sex as coerced or otherwise rape. So this is a number of young girls whose first sexual experience is frankly rape. It's very infrequently prosecuted, and we really wanted to focus on ensuring that we could start a justice element to prevent rape in the community. So the first goal is to prevent sexual violence against children, protect children served by PEPFAR throughout our communities against sexual violence, and have communities take that on, both the churches, the tribal leaders, and others, to prevent the rape of young children, and to facilitate the disclosure, reporting, and system response, holding perpetrators accountable. And we think this last bullet is absolutely key to the success of the program. So we really believe in PEPFAR. We are trying to meet the needs of children, adolescents, and young women with HIV through their life cycle approach, beginning, of course, with our fundamental programs in prevention of mother-to-child transmission, and ensuring that there's access to unique services, particularly to young pregnant women, then ensuring that all exposed infants are followed through childhood, through our Orphans and Vulnerable Children's program, through our adolescents and youth programs, both DREAMS and circumcision, and then into young families to ensure support. I wanted to give you our most recent treatment numbers. So this is through the second quarter of fiscal year 19. This is for young women on treatment. We have about 1 million young women on treatment between 25 and 29, and about another 600,000 between 20 and 24. These numbers really help us. This granularity allows us to compare countries of coverage and how we are doing. It also lets us look very specifically at viral load suppression as well as retention. So again, numbers are only important if it allows you to see through your perceptions down to the reality of what the client is experiencing. We've also increased our investment in cervical cancer, and I just want to highlight that because it's been over just the last 12 to 24 months that we dramatically expanded our cervical cancer budget, because we realized this was greatly impacting HIV-positive women, particularly young women. I wanted you to have the most recent data, and thank you, Heather Watts, for getting this for me. This includes just through the last quarter, how many women were screened in each of the age groups by 5-year age bands. And again, these trend analysis, one data point is nice, but it's really the trend analysis of using that data over time that allows us to both increase the validity of the data and the importance of the data and the use of the data. And this is the number of women who were treated by age group, and this is encouraging to us that it matches the need and the screening. And so we're actually finding and treating, and I want you to look at both the 20 to 24 and the 25 to 29-year-old age band and see the number of leaps that have already been required in this very young, very early age band. And that is why we've really markedly increased our investment to ensure that young women have access to really secondary prevention. We would like them to all be immunized with HPV vaccine, and we're working on that. And I think this is really giving us a real opportunity to understand the risk for young women. So PEPFAR invests about $2 billion a year in supporting women and girls. It is all based on looking very carefully at performance of the program and how we can do better. We have countries that are extraordinarily top performers, and we're using them to learn from so we can improve the performance of all of our countries. We're confident that the DREAMS partnership is not only working, but continues to show a greater and greater impact on the rates of new infections in young girls. Of course, our 2 million female orphans and vulnerable children that we're supporting, our continued focus on prevention of mother-to-child transmission, and also supporting very young pregnant women, and then our investment in cervical cancer. So again, I hope I've convinced you that data collection and analysis is only valuable if it's used continuously to improve program implementations and change policy. I was very taken yesterday when we all sat in this room and saw Dr. Fauci's new toolboxes. I love the way he showed them as toolboxes. We have a very filled toolboxes for prevention. We need to ensure, both with key populations and our vulnerable groups, that we're ensuring that they have access to those tools that have been given us. Thank you for the privilege to be able to work with these incredible adolescent girls and young women. We're privileged to be able to partner with them and our DREAMS teams around the globe. Thank you.
Thank you, Ambassador Birks. And now we'd like to welcome Professor Osamu Kuni to the podium. He serves as Head of Strategy, Investment, and the Impact of the Division of the Global Fund to Fight AIDS, Tuberculosis, and Malaria within 5 departments, including Strategic Information, Technical Advice and Partnership, Technical Evaluation Reference Group Secretariat. He has worked for more than 25 years in global health in over 100 countries, especially focusing on maternal and child health, infectious disease control, health systems, health policy, and diplomacy. He has also served as Deputy Director of Aid Planning in the Japan Ministry of Foreign Affairs and is a Professor of Global Health at Nagasaki University Research Institute of Tropical Medicine. And as well, he has been Senior Health Strategy Advisor at UNICEF. Dr. Osamu.
So thank you very much, IAS, for inviting this very important session. Today, I'd like to talk about data collected in Global Fund for designing the HIV responses and maximize impact. In Global Fund, data are at the center of successful planning, implementation, and improvement of programs. So we use data for various purposes as shown in these slides. So to achieve the Global Fund strategic objectives, that we have developed the data use for action and improvement framework we call DUFI framework. It is aimed to ensure good quality data are available, required analysis are performed at the country level, and data are used for decision-making at all levels to drive program improvement. One of the most important Global Fund principles is to respect country ownership. So we support countries' robust monitoring, evaluation, planning, and capacity building for improving data availability, quality, and use. This progress in this framework are measured using 20 indicators and targets. This DUFI framework consolidates all reporting requirements, including the implementation of strategy, KPIs, risk management, and other key metrics. Data are used for tracking the progress toward the Global Fund strategic target, especially by KPIs. We have 12 strategic KPIs and 14 operational KPIs for tracking the progress at grant, country, and global level. To facilitate data analysis and visualization for routine grant management, Global Fund developed data and analytics called DNA. It is tailored to the needs for global, regional, country, and grant-level data on health financing, programmatic, financial, performance, risk, and decision process. It is linked to a specific dashboard aligned with the reporting and disbursement cycle. Data are also used for the fund allocation. In the basic allocation formula, global fund use ability to pay, that is GNI per capita, and disease burden, in the case of HIV, number of people living with HIV. Then we make a two-stage qualitative adjustments using data of HIV prevalence and incidence among key populations, their size estimate, cost for essential services, coverage gap, etc. Since this is the year of global fund replenishment, the pledged fund will be allocated to eligible countries by the end of this year. So currently, revision of this allocation methodology is under discussion in the board and its committee. Data collection and use are the center to grant design, implementation, performance, monitoring, and evaluation throughout entire grant cycle. Before the funding request, all programmatic data are analyzed with other quantitative and qualitative data to define epidemic staging and progress toward national strategic plan targets. In the analysis, several key questions have to be answered. What worked and what didn't work? And which service delivery models are working? Which geographic locations and also subpopulations should be covered? Such analysis usually coincide with the national program review, and the results are used for investment case development, prioritization of service and delivery models, and targeting. These inform the funding request for the 3-year funding cycle. The results are also used for revision and development of national strategic plans and national monitoring evaluation plans. The programmatic data analysis is done throughout all the implementation period with data collection and service delivery. At national level, the analysis focuses on the prevention, care, and treatment cascade, not only taking the progress, tracking the progress, but examining problems and good practices across each step. With PEPFAR, WHO, and UNAIDS, we conduct ART, data audit, to inform the program planning, adjustment, and estimation. Besides, disease-specific data system, we also invest in a national data system, including DHIS2 and supply the logistic information system. As a performance-based agency, grant performance is primary parameter for disbursement decision. In the first step, we rated performance of indicators in grant performance framework based on verified result against the agreed target for the reporting period and categorized as A1 to C. In second step, we decide the indicative funding range based on the indicator rating as shown in middle. In third step, we factor in the financial performance and other grant management parameters to derive the grant rating, which will be used to define the final disbursement. Grants are usually downgraded due to the data quality of financial management issues. In addition, we regularly analyze and use data to adjust program implementation and inform national policy change during the grant implementation. This is an example of Lesotho on how we use data collected to inform policy change. As shown in the graph, the testing yield has been going down, especially after 2013. Yet, in 2016, National HIV Testing Service Guideline didn't respond to the declining trend. With data analysis done in 2017, issues were clearly identified, including high volume of testing, high rate of repeated tests, and declining yield, along with increased implementation cost. In response, Global Fund, working with government and PEPFAR, facilitated the revision of national HIV testing service strategy, set differentiated service delivery to targeted groups with a focus on high-yield testing modalities, such as testing among TB patients, index testing, and partner notification. Targets were set not only for number of tests done, but with yield, which is backed by regular test data analysis for any possible program adjustment. Currently, we are seeking an innovative way of data collection and use for improvement called community-based monitoring. Compared to the traditional models of monitoring, it might have added value of facilitating bottom-up approach and applying service users' experience, increasing community engagement and buy-in, and creating shorter local feedback loops. For example, Global Fund has started investment in this community-based monitoring by granting 3.6 million euro to implement a regional community treatment observatory in 11 Western Africa. The grant supports the national network of people living with HIV in each country to collect and analyze facility-level data among the HIV care continuum. It also supports data-driven advocacy at the national and regional level for improved service provision. Its report shows solid data collection and analysis, and short-time feedback loop for advocacy and actions to promote differentiated service delivery, non-facility-based HIV testing, and communication to proven stockpile. As way forward, I'd like to highlight 3 things. First, we need to seek smarter investment to fill the gaps and strengthen in-country capacity in data system, especially for addressing bottlenecks in achieving targets. Second, annually, we invest about $2 billion for fight HIV, and also over $200 million for data system, but it is not enough. In this year, replenishment of Global Fund is now going on, and we need to raise at least $14 billion for the next 3 years cycle, and has to play a catalytic role in increasing domestic financing. We have to make successful replenishment this year. Third, better data and its use are everyone's matter. Strategic partnership with coordinated or joint planning, implementation, and monitoring evaluation is key to success in accelerating our effort to fight HIV and end HIV epidemics and achieve SDG goals. Thank you, my team, for all the great work on monitoring, evaluation, and data. Thank you.
Good afternoon, everyone. Now it's my pleasure to introduce Navindra Persod. Navindra Persod is a medical epidemiologist and the Strategic Information Team Lead for the USAID-funded Global Linkages project. Here, he leads the Linkages Data Initiative, a project-wide effort supporting the use of data to design and implement evidence-based programs for key populations. Dr. Navindra?
Thank you very much. I'm happy to have the opportunity to share with you today some of the data-driven approaches the Linkages Project is using to design and guide implementation of HIV programs for key populations. I have no conflict of interest to disclose. Linkages is USAID's global flagship KP project funded by PEPFAR. And since it started in 2014, Linkages has worked in 35 countries and is currently active in 29. Linkages was designed to increase the availability of comprehensive HIV services to key populations, increase demand for these services, and strengthen systems to support evidence-based quality programs, which is what I will address during this presentation. It is well documented that KPs are at greater risk for HIV. KPs are not a homogeneous group, and due to stigma, criminalization, and other structural factors, are harder to reach with comprehensive programs. Moreover, KP who access services typically access them at a variety of service delivery points, from community-based service providers and drop-in centers to public and private clinical facilities. All of this makes it extremely challenging to develop data systems to track KP individuals along the cascade and monitor KP programs. To ensure that linkages programs are based on high-quality data, our strategic information framework is built on 3 pillars. First, we utilize data from different sources in order to understand the size, distribution, needs, and dynamics of key populations in the target areas. Second, these data are used to plan and implement prevention and testing services for KPs, developing interventions to ensure that those newly diagnosed are enrolled and retained in treatment, and to continuously engage and re-engage both HIV positive and HIV negative KPs for services. Third, systems are put in place to support the generation and use of high-quality, routinely collected data to track performance across the cascade and for measuring outcomes. I will now show examples of these from different countries. This slide shows why KP programs need a robust and current understanding of the target population size and location to guide program implementation. Using programmatic mapping in Burundi between 2016 and 2018, we found substantive changes in the number, distribution, and location of KPs in 4 of the 5 provinces in which linkages works. This was critical data to have so that our implementing partners could be redirected to ensure adequate coverage in all provinces. Once a KP program is up and running, a comprehensive cascade that captures data on services provided to both HIV positive and HIV negative KPs is needed to understand the reach and coverage of KP programs. Traditionally, we estimate population size, then report on the number reached with prevention and testing services, and then develop treatment cascades for those who are HIV positive. But comprehensive monitoring of KP programs requires more nuanced systems to understand their impact and to improve performance, as well as systems to understand what services are accessed by HIV negative KPs to ensure that they remain negative. Such comprehensive monitoring also requires data that are not captured by the standard HIV program indicators, but entails the use of custom indicators. Custom indicators that work together or complement the standard HIV program indicators are needed to fully understand what is happening in your programs and to make adjustments. Collecting a little more data goes a far way in helping to develop a comprehensive view of your KP program. Take, for instance, prevention. Whilst knowing the number of KPs who are reached with prevention services is important, collecting a little bit more information about clients' testing status provides greater insights into their needs and support developing individualized plans. As shown in this graphic from our project in Côte d'Ivoire, approximately 10% of the female sex workers who were reached through our prevention programs were not eligible for HIV testing, as they were recently tested and had no additional indicator for testing. 20% refused to be tested, and 1% already knew they were HIV positive. This information, coupled with risk assessment and socio-demographic information, is used by outreach workers to develop individualized plans that meets the needs of female sex workers. On the treatment side, at Linkages, we developed and applied a number of custom indicators to better track uptake and retention by all HIV-positive KPs who were reached by the project. First, TX-Link New is used to track those key populations who were tested HIV-positive by Linkages, but opted to receive ART at a treatment facility that is run either by another partner or government. In this way, we can account for all KPs newly diagnosed with HIV. Second, HIV-positive KPs who have dropped out of treatment but reached by our outreach workers are relinked into treatment facilities. KPs returned to treatment in this way are also tracked by another custom indicator, which we refer to as TX-Link Return. Third, in addition, many KPs usually enroll in KP-friendly community-based organizations where they receive non-clinical support, ensuring they remain on treatment. This support is not tracked using the conventional indicators, but is done by Linkages using a custom indicator. While PrEP has been shown to be effective in reducing HIV transmission in KPs and is offered to KPs as part of the comprehensive prevention package, the standard indicators only measure initial PrEP uptake and those currently on PrEP. To understand the dynamics of PrEP uptake, we have developed a series of custom indicators which helps to explain the various stages of the PrEP program and identify where losses are taking place. This graphic shows a PrEP cascade among HIV-negative KPs in Lesotho in Q2 of FY19. Of the 1,300 KPs who tested HIV-negative and were offered PrEP, 55% accepted a referral for PrEP. 37% declined, and 8% indicated that they needed additional time in order to determine decide whether they actually want to use PrEP. And of those who accepted the referral, 43%, we were able to verify that 43% of them actually initiated or started PrEP. And I'd also like to add that we all have additional custom indicators which we use, which are used by Linkages to track continuation on PrEP. Analyzing data to assess performance of partners help target technical assistance to those partners and program areas where it is needed most. This slide shows two examples of how this data is presented and reviewed. The slide on your left shows one way of presenting the data in our project in Laos, which looked at case detection rates by different partners up to the end of Q2 of FY19, whilst the table on the right shows another way of presenting data from our project in Côte d'Ivoire, in which we looked at performance for all of the key indicators across partners up to the end of Q2 in FY19. Lastly, we also conduct granular analysis of site-level data to assess reach and coverage at the various hotspots to help identify gaps in service delivery. For instance, in Angola, which is shown in the graphic on the left, by analyzing the hotspot level data, we found that outreach workers were going more frequently to the most easily accessible hotspots. With this data, we sat with the implementing partners and reprogrammed the outreach schedule. And by enhancing outreach to the hotspots that had been undervisited, we observed an increase in HIV case finding. The graphic on your right shows another way of presenting data from our project in Côte d'Ivoire, which looked at HIV case finding or variation in HIV case finding among female sex workers in different health districts. In summary, therefore, ladies and gentlemen, data for planning KP programs should be regularly updated using both systematic assessment as well as data from routine information systems. Custom indicators are necessary to build a comprehensive picture of KP programs and to make improvements. And finally, granular analysis of these data on a regular basis can allow for greater precision in targeting implementation or targeting the various tools available for HIV prevention and control, and providing technical assistance where it is needed most in order to improve program performance. Thank you.
Thank you, Dr. Prasad. In the time remaining, we'd like to have a brief dialogue with our speakers, and first starting with asking Ambassador Birks to reflect on some of the data that we've seen related to key populations. Ambassador Birks.
Great, and it's a perfect opening, starting with how we're doing globally with key populations and the fact that we have this information, this data, and successful programs that are piloted, not taken countrywide to scale, because in many of our key population epidemics, we have small budgets, and what we thought would happen is those would then be taken to scale by the country principal recipient or through the governments itself. And I think seeing how great the linkages data is, and I want to ask two questions. One, when you talked about key populations being very different, maybe you could just talk for a second about the difference in the size population and ability to reach them in different countries, and then the ability to refer and keep on treatment. And then secondly, what would be your recommendation to really, in many of the key population epidemics throughout the Caribbean, Latin America, Asia, Central Asia, how do we get these promising programs that you have been able to realize through linkages and other partners, how do we get them to scale today? I feel like we have Dr. Fauci's toolbox fully filled and evidence of successful pilot implementation, but not the ability to take it to scale.
Yeah, so thank you very much for raising those two issues. So the first one in relation to population size and for ability to reach key populations in different settings. Certainly, we have found through our program implementation that current methods we need better methods for estimating key population size in different settings, since the current methods are not always applicable or suitable for all populations in all settings. So that is the first thing. Secondly, we also need to, whilst estimating the population size, not only count the numbers, but also understand the dynamics of the populations, their needs, what services are currently accessed, what services they do not have access to, and then use all of that information along with other epidemiologic data in order to plan appropriate intervention programs. Third, we've also found that key populations are very different in different countries and even in different, let me phrase that differently, sorry, yeah. So we found that key populations are not a homogeneous group. They're different in different countries, and even within the same country, the same key population may exhibit different behaviors and different dynamics in different geographic areas in any given country. So understanding those issues and taking all of that into consideration in designing, helping to design, using that data to design appropriate programs. On the question of taking these promising programs to scale, I think what's needed is for us to work together, all of the implementing partners, linkages, PEPFAR, Global Fund work together in order to identify governments, to identify the promising programs and bring those to scale.
I think that's really the key issue, and I don't mean to call out a country, but it's pretty stark. I mean, when you look at Indonesia, one of the countries that has a very effective health system, our coverages of services of treatment is at 15%, and our coverage of prevention is less than that. And I think we do have very promising practices, and even a promising practice in Indonesia. And I think what we need to really figure out is how different groups and different bilateral groups like PEPFAR and others that have investments in different regions can really ensure with this concept note development that we're going to move these promising tools and evidence base to scale. Because again, it's not worthwhile to have all that data and this wonderful data that you just presented if we're not going to take it to scale throughout countries to ensure we just change the dynamic. And I don't want to be back here with another round of concept notes and have Indonesia at 30%. I think there is a way that we could really, with policies, get to a different place.
If we could ask Dr. Cooney, Professor Cooney, to also comment in terms of the Global Fund's efforts to take data, particularly on key populations in areas like regions that are struggling so much, perhaps that don't get quite as much investment from Global Fund or PEPFAR, what could be done to scale up data systems as well as leading to direct program improvement?
Thank you very much. I really thank Debbie, PEPFAR's contribution and also of course linkage for really generating great data. And what we can do as a Global Fund, we are, as you know, Global Fund is a partnership organization, so we cannot directly prescribe the countries to the focus on certain key populations. But we have a kind of the good mechanisms like a technical review panel, really look at the old kind of data and whether that concept note is appropriate or not. We just check. And sometimes, the planning is good, but sometimes implementation is very difficult. So at the time, we have opportunities every year for reprogramming. We also have a portfolio review, almost kind of, very frequently. So we check and try to reprogram, support, reprogramming. And we have good technical assistance from PEPFAR, CDC, and others. So we utilize those for this kind of reprogramming and also a better concept note development. But at the same time, we also monitor investment in these key populations. Nowadays, we have some of the good key KPI. Of course, it is not perfect, but we try to just check and track how much they are really investing. And we also have a kind of a catalytic role to increase domestic financing, not only just amount itself, but also directing to the key populations. Nowadays, we really have to take care of this focusing and prioritization in key pop, and also reducing that infectious cases. Thank you.
And perhaps if we could put Dr. Lopez-Gatell on the spot in terms of what's being done here in our host country of Mexico to focus on issues of not just data, but also in particular key population program strengthening.
Absolutely, thank you very much. Yes, I have a few notes to share with you. One is we are convinced that data generation and intelligent data use to inform policy, design, development, evaluation, etc., is crucial. But a long-standing challenge has been to develop really extensively the culture of data use into policy development. So at the end of the day, one may have theoretical expectations of the importance of data use and data crafting and data analysis, but then there's a point of breakage in the process of policy development. And that's why we believe that it is important to really feed the need for data, the data culture into the communities that are affected directly by all sorts of problems, not only the technical perspective of the problem itself, say the AIDS epidemic, but in generally how development is linked to good or bad decisions and how those decisions can be improved by having an analytical approach. And one final note is that in that regards, we believe it is important not to lose the idea of a horizontal dialogue, an inclusive dialogue between all parties, academia, society, organized society and unorganized society, political friends and political foes. The criticism is really favorable to the cause of developing new perspectives, widening horizons in how policy is developed.
And if I could, the final question back to Ambassador Birks in terms of investments that PEPFAR is making in data strengthening, and particularly with regards to key populations.
So thank you. We've invested a series of financing in a new way, really to bring data systems across the health spectrum. And we haven't brought in education and others, but I think once we get integrated health data, which we're working with countries now, because I think that will increase data use. I mean, we want data use in general, so I think if we integrate all of both the commodities, the supply chain, and all of the diseases into one place, that ministers of health, really around what the UNAIDS model has been with their fast-track cities and fast tracks, the Kenyan dashboards are incredibly helpful, and I think it's our job to create data that's relevant to the policymakers in a way that everyone can understand it. And I think we have incredible data people, but they can look at an Excel spreadsheet and they are good to go. I have no idea. So, you know, I have to make graphs and I have to look at it, but I mean, everybody has to digest data differently, and I think that has been one of our biggest gaps, is making data actionable because it's graphically represented in a way that everyone can understand it. And I think that's where we're really going. We've dramatically increased our investment in that, both within PEPFAR for our own use, but also with all of our host governments.
Well, thank you so much. This was such a treat, not just being able to hear the presentations, but also to have this post-presentation discussion. So please join me in thanking all of our speakers and my co-chair, Undersecretary Lopez-Gatell. Thank you so much for joining us.